From overcrowded emergency rooms, surgical backlog, ongoing staff shortages, not to mention an ongoing pandemic, Ontario's healthcare system is ailing, much like the patients it's struggling to care for. You would think we would have figured this out by now. To discuss why not, we have joining us in the downtown of the provincial capital, Dr. Ronald Cohn, President and CEO of the Hospital for Sick Children. And joining me in studio, Julia Hennesberg, President and CEO of the Holland Bloorview Kids Rehabilitation Hospital, as well as Chair of the Board of Directors at Children's Healthcare Canada. And Alan Odette, CEO of Ontario Medical Association. Welcome to you all. All right, so let's take a look at some fast facts about the state of Ontario's healthcare system and hospitals. The province has an estimated 22 million patient service backlog. That includes over 1 million surgeries. In October 2022, patients were waiting an average of almost 23 hours in the emergency room before being admitted. Ontario also has 2.3 hospital beds per 1,000 people, and the vacancy rate for registered nurses, including those with specialties, hit 12% last March. Alan, I'm going to start with you. How is Ontario doing when it comes to its health system, when we talk about its performance?
So that's a big question. I think it's pretty clear that the healthcare system is under a tremendous amount of strain, and it was under strain prior to the pandemic that we've been experiencing the last couple of years. We have some fundamental issues with regard to human health resources, and that's physicians, nurses, I would dare to say other allied health professionals. So we have some major challenges that we need to overcome. We need to do that collectively. It's not really a task of government. It's leaders like those that are joining us here in studio today. The challenge that we do have is it's been exacerbated by this pandemic. The cracks were there already, I think. Important to remind ourselves sometimes that while we do have significant challenges and these problems are big, we do still have a pretty good healthcare system here in Ontario and frankly right across Canada. I had an opportunity to travel before Christmas, and while we have problems and it's not perfect, we also need to think about putting it into some context and comparing it to around the world.
Julia, I want to get your take on that as well. How would you sort of, I won't say grade our performance, but how are we doing?
Well, I'm going to start where Alan left off, which is what's working really well. We have extraordinary healthcare workers in this province, people who are incredibly dedicated to their work, extraordinary in terms of their capacity to provide care and their commitment to care for all Ontarians. We see this every day, leaders like Ronnie and I in our organizations. So we're building off that strong foundation. I think during the pandemic, has been a bit of a never let a good crisis go to waste. So we've been working together in ways we've never done before. And that's a positive as well. But this is a crisis of today, decades in the making. And so it's not going to be a quick fix. There's no magic fairy dust. But I think there are some important ideas, and what we need is a plan, and I'm looking forward to talking more about that today.
All right, we'll talk about that a little later on. Ronnie, I'll get your take from a pediatric sector. Which of these issues, the ones listed and the ones we're going to be talking about, would you say are chronic, and which ones are acute?
Yeah, that's exactly what I think is important to delineate for everybody. We have over the last few months experienced an acute crisis of children with all sorts of different respiratory virus infections coming to emergency rooms, having been admitted to the hospital at unprecedented volumes. And that has led to a further exacerbation of the chronic crisis of children waiting way too long, sometimes twice as long as adults, for surgical procedures, for diagnostic imaging, for mental health services and rehab services. So while these are two different crises, they are intricately linked, of course. And if you ask me, there are a lot of positives, as you have heard from Julia and Alan, and it is and starts with our healthcare workers that are above and beyond and have been going above and beyond for the last 3 years. But I also think it's important to recognize that we are in a somewhat unacceptable state right now. I say that as a pediatrician, as a father, as the head of a large children's hospital. It is unacceptable to me that children have to wait so long. And these are the problems. We have to all take a step back and admit that this is untenable. And if we do that, then we can actually work on the solutions moving forward to fix this.
Julia, as I mentioned off the top there, we're talking average wait time for emergency room for people to be admitted, 23 hours. That's a full day stay. It's like going to a hotel. Can you break it down a little bit? What are the variables contributing to that particular issue?
Well, as I'll speak from the children's healthcare perspective, and with a national view as well as from a Children's Healthcare Canada perspective. As Ronnie has said, we in this fall, and really starting in the summer, we saw the first cases of RSV in children, and that was unprecedented. And that's been across Canada, it's been across North America, and it's actually been a global phenomenon. We've seen that in the UK as well. So an unprecedented number of children who needed care. You add to that reduced access to common medications for children, acetaminophen, ibuprofen, common antibiotics used in children. So you had this combination of families not being able to manage typical illness at home. And then, of course, the underpinning of our healthcare system is primary care. Those physicians out in the community, nurse practitioners, those teams that really keep our system going. And when you have a lack of capacity there, people do what, of course, they should do, which is they come to the hospital. And we've seen during the entire pandemic the way the hospital system has been the backstop for healthcare. When long-term care was in crisis, hospitals were there to help. And so we rise to that occasion. But what this has all really shown us is that we have a system under strain. From a children's healthcare system perspective, it is an undersized system. It is too small. And so, what we've said to government, and this is with Ronnie, with all of the children's hospitals in Ontario, as well as children's mental health, children's rehab and developmental medicine, we need to right-size the system for kids so we have the flexibility to deal with a crisis, to deal with a surge, and to do it safely and with quality. With the backlog we have, if we keep doing the same thing, we will literally never catch up. And so those children who are waiting for surgery, even just this fall, another 900 surgeries postponed, they will never get, in a timely way, the care they need unless we change how we work.
Ronnie, in November, SickKids canceled non-urgent surgeries to preserve critical care capacities in ICUs. Your hospital is not the only one that sort of went that route, who was forced to make very difficult decisions. What will it take, as you mentioned, for us to make a dent in the province's surgical backlog?
So, as unprecedented as the volumes have been that you have heard about, I would like to also mention as unprecedented has been the response from a systems point of view. We have established now collaborations between a tertiary care hospital and community hospitals who have the ability to take care of pediatric patients like never before. We have come together like never before. And I think this is going to be one of the key issues that we have to leverage moving forward, because this systems response actually has, thank God, prevented any kind of sentinel event in a child so far. And by creating this new capacity, moving forward will allow us to have surgeries of lower acuity happening within the community, for example, so that children's hospitals like SickKids and other tertiary care hospitals can focus on the more complicated surgeries. And that, in addition to right-sizing the pediatric healthcare system that really has been undersized for over a decade, if not longer, as Julia said, I think is a path forward that will allow us to tackle that problem.
Alan, I'm going to get your take on that.
Yeah, you can. And it's interesting and I think helpful to hear people trying to collaborate the system has been absolutely under siege for a long time, as Julie overtured earlier. We spent some time at the Ontario Medical Association the year before last. We went out to about 10,000 Ontarians, several thousand physicians, 110 other organizations from patient groups to business associations, et cetera. And we wrote a prescription for Ontario, which is essentially a plan over the course of the next 3 to 5 years to fundamentally strengthen the healthcare system in this province. And a couple of things that came out of that recommendation are some things that we can do in the very near term, some things that we could do in the longer term. Human health resources is a critical issue. Everyone is overworked. They're fatigued, they're burnt out. Physicians, nurses, hospital administrators, I expect as well. So we need to take some steps to license some more foreign internationally trained physicians. We need to think differently about care in hospital. We could be doing more day surgeries outside of the hospital setting. We need to build that ambulatory infrastructure outside of the hospital and take advantage of that. So as Dr. Cohn described earlier, we can use those settings for more critical types of surgeries. We need to think differently about palliative care. You know, we have a lot of patients in hospital, in palliative settings. We need to invest in community care. I had an example just yesterday of one of my colleagues at work who traveled to London, Ontario, and a family member had been discharged from a hospital with essentially no community support. If we were to strengthen palliative care, create more hospice beds, strengthen the model of care for people in their home, that's going to take some of the burden off of the hospital sector.
I want to stick with you for a little bit. You talked about foreign trained physicians. What's stopping us from licensing more right now?
Well, there's a couple of things. I can tell you that the Ontario government, the college, and the OMA have been working for quite a number of weeks on trying to remove some of the hurdles and barriers to that. One of the challenges is oversight. You need other physicians to ensure that these foreign-trained physicians are practice ready, that they have a mentor, that they have somebody that has oversight to help integrate them into the Ontario system. You've heard from all three of us that we're operating well above capacity in terms of human resources. The strain on, I'll focus on physicians for the moment. You know, self-reporting, 2/3 of Ontario physicians are tired. Many of them on the verge of burnout. So they just don't have the capacity. You have this, some 20 million services that have not been provided. Those patients are now showing up in primary care with significant comorbidity, with complex disease. Physicians are working about 10% more now than they did pre-pandemic. So you have that challenge of oversight and mentoring to help integrate some of these folks into the Ontario healthcare system. But I can tell you the Ontario government, the college, and the OMA is committed to supporting that.
Comment on the healthcare human resources issue. We are a chronically exhausted healthcare workforce, and we've gotten used to that. We actually have gotten kind of addicted to it. We have come to expect that people work overtime. We've come to expect that hospitals, you know, the part that I know best, operate at or above capacity. It's very normal for us to say we're operating at 100% capacity or more. We expect our nurses to work overtime. We actually don't have a workforce built that people can work a 37.5-hour week, which is what you would kind of expect we would have. So we are making these very important jobs extremely hard to do, and we're making them less and less attractive. So as much as it's super important to bring in the foreign trained professionals across the board, including the physician group, and there's lots to be done, we really need to work on retaining the existing expertise we have in healthcare. These very specialized providers that, in our organizations like Ronnie's and my own, we need to create quality of work and life that is going to be sustainable. And that includes compensation that is a living wage for people. And it includes what we expect of them in terms of their day-to-day work.
I was going to sort of come to you for sort of the human resources perspective, because off the top, they talked about sort of, the low number of hospital beds per 1,000 of residents. It has been an issue here in this province for a very long time. But when you have this burnout, how do you square that?
Well, this is the issue, right? I mean, we have prided ourselves in Ontario for our efficiency. But the flip side of efficiency is that you have this capacity issue that's been growing literally over decades. And now, because of the pandemic, we have seen it really rise to crisis proportions. You also have, we haven't had the ebbs and flows we usually have, so people haven't gotten a break. Summers usually get a little bit quieter, less viral disease, et cetera. That hasn't happened. It's been flat out. And then, of course, in children's healthcare, this fall has been extraordinary. So what we see in terms of burnout, we see exactly what Alan described. What people want is to do the right thing for their patients. When I talk to members of my team, as I do all the time, what I hear is their burnout, their sense of exhaustion is because they know what their patients need and they know they can't get there. They can't do what it takes. And that is, that's fundamentally at odds with the values people bring into these professions. When people go to medical school, they become physiotherapists or nurses. It's because of that kind of impact they want to make on people's lives. And so, part of this does come down to funding. It comes down to how we compensate people and making sure that those bedside nursing jobs are incredibly attractive jobs. Nurses can do lots of things. They're very, very talented professionals. They can work in public health. They can work for organizations like yours, Alan. They can work in government. We've got to make sure bedside nursing stays a really attractive job because it's a hard job. That's just one example, but across the board, we need to keep these jobs attractive. We need to retain the workforce we have. We won't be able to recruit our way out of this if we continue to lose people.
Ronnie, I'm going to get your take on this as well.
Yeah, so thank you. I want to emphasize that the issue that Alan referred to in regard to physicians is really applicable to the entire healthcare force.
Yeah.
And when we are talking about retaining currently existing individuals within the system, these are the people who are not only providing this extraordinary care, but who are going to train the next generation. It's wonderful that we have been able to recruit a lot of new healthcare professionals into our systems and hospitals or other parts of the system, but we need the experienced people who are currently working to educate them, so we will have an ever-growing health human resource force that is actually able to provide this high quality of care. So the issue of burnout is universally applicable, and retainment has become as much, if not maybe an even slightly more important issue than recruiting, in order to make sure that the expertise that's currently existing can stay with the system.
I'm actually going to bring in Cynthia Davis out of Corner Brook, Newfoundland. She is the president and CEO of Lakeridge Health in Durham Region. Thank you so much for joining us in this conversation.
Thank you for having me.
All right, we've talked a little bit about sort of where we're at in terms of the healthcare system and what we've dealt with, and we've talked about sort of a human resourcing concerns. But I want to get your take on how has Lakeridge Health been handling delayed surgeries and procedures over the last year?
Well, like other organizations throughout Ontario and really throughout the country, when we have been asked to pivot and to change some of our delivery in order to meet the demands that were changing, we certainly did that. And one of the things that we did were we switched some of our surgical procedures for sure to outpatients. We prioritized the ones that needed to be done. And then unfortunately, we also saw some delays. What I can say is that for the past year, we have rapidly been on a recovery plan with our surgical procedures. And for Lake Ridge Health, which is a system of healthcare delivery in the Durham region, we've been able to, ramp up our surgical procedures in many of our facilities, and our recovery plan is going quite well. What that really meant, I think, was a dedication for us to understand that as people had delays in their surgical procedures, we needed to give it the same attention that we did with other pressures in our system throughout the past 2 years. So for us, we looked at dedicated beds. We looked at shifting outpatient procedures where possible. We leveraged virtual technology to support pre and post-op care. And then we're also looking for a new surgical center that's opening in North Durham this summer. And we were well on our way with that build. And that really is about shifting surgical procedures that can be safely done in a community-based setting and allowing us to do more complicated inpatient surgeries within our main facilities throughout Durham. So I can say that we've continued to respond and rally to meet the needs of our community and the care we're providing.
Cynthia, I'm going to stick with you. I have another question for you. The Ford government introduced what many considered a controversial bill, Bill 7, mandated moving elderly patients who no longer needed acute care into nursing homes. In mid-December, the Ford government said that the bill had cleared about 3,400 hospital beds, but it didn't necessarily result in shorter wait times because of just the sheer number of people that needed urgent care in the recent months. What do you think about the bill, and do you think this bill will pay off in the future?
So what I would say about Bill 7, and you described it very well, we had a number of people that were waiting in hospital that no longer required acute care. And it's interesting because my background's nursing. And my focus really has been over the past couple of years is trying to understand how our system can respond to the needs of the elderly people that we're caring for. And this notion that while you're waiting in hospital for something else when you don't need it is not a good place to be. It really is a place that's geared for acute treatment and response. And so every day that somebody's lying in a hospital bed, and I say in pajamas, that they don't need to be is not good for not only their physical health, but also their cognitive health and social and well-being. And so Bill 7 allowed us to have those conversations, I think, with people, that when you arrive in hospital, we want to provide the best care we can as quickly as possible. And we also want to transition you and help with those transitions to the places that you can be cared for safely. What we've seen in our system really is that Bill 7 has been just one more thing that we've done. Through government funding, we actually have enhanced our activation and mobilization teams to prevent deconditioning in hospital. We have funding for transitional care beds, and we also had funding for enhanced geriatric care within our emergency department. So all of these things together, I think, were things that really were trying to leverage all of the resources effectively. I can say that within Lake Ridge Health, we have not seen a big flow associated with Bill 7. And what we've continued to articulate is that we want to provide every single opportunity for alternatives. But at the same time, this is an important thing for us to do. If we need to, and if we have to implement it, it is with compassion and kindness, and we have supported Bill 7.
All right, I'm going to change gears a little bit. I'm going to talk about money, because it's not a guarantee that more money means fewer problems, but it does seem like there's some conversation there. The federal government and premiers are at an impasse right now in their fight over healthcare funding right now. Canada's premiers say the federal government is only paying a quarter, 22% of the cost of providing healthcare. They want 35%. As executive leaders at some of the province's biggest hospitals and organizations here, how do you think that massive bump in funding could change our medical system and access to services? I'm going to come to you, Alan.
So Yeah, we need more money. We can always use more money. You know, the Canada Health Transfer Act originally, I think, was set up to be a 50-50 share, and that's kind of fallen off over the years. I've publicly come out supporting an increase in the transfer, but it's not money. It's not just money we need. When I listen to this conversation, and I'm so pleased to hear the advancement in you know, out of hospital surgery and surgeries that can be done in the new surgical center out in Durham. I think that's fantastic, because it's one of the top recommendations that Ontario doctors have made to increase surgeries in out of hospital ambulatory settings. When we think about burnout and capacity, whether it's human resources, hospitals, or otherwise, it's about integration. It's about deploying the resources better that we currently have. You know, right now we can't even link digitally. We have 8 doctors out of 10 faxing because the electronic medical record isn't connecting with the lab or you know, another specialist or the hospital. That's absolutely, I use this expression, cuckoo bananas. That is crazy that we're doing that. These are simple things that we ought to sort of focus on. When I think of and about capacity and burnout as it relates to the men and women who I work for, physicians in Ontario, for every hour that they're touching a patient, they're spending another 30 to 45 minutes doing paperwork and administration. It's something that we could actually get at if we were to reduce that administrative burden even marginally, an hour a day. That's a couple of extra patients. It's about 60,000 a day across the province, and it's almost 1 million patient visits each month. So there are some things that we can be doing, and I'm encouraged by the discussion this morning. We are doing them, but I think it's going to take some courage and leadership of the people who are in this room and others to say, what is the problem that we're trying to fix? And at the center of it ought to be our families, our neighbors, and our communities. And the patient really needs to be put at the center of it all.
Julia, in your conversations with provincial government officials and health authorities, are you finding that they are fully engaged and committed to fixing these problems?
Yeah, I'd say the answer is 100% yes. It's unfortunate we had to get as far into a crisis as we've had to get as much attention in the children's world, for example, and in children's health care. But I think we are really engaged with those government officials. We had Minister Sylvia Jones over at Holland Bloorview just before the holiday season, and she sat down with my team and was asking those questions. What are the policy changes? What are the regulatory changes? What would make long-term impact? So I think that the government is really seized with those questions, and we're pleased to be there. What you're hearing from all of us is capacity, system. Yes, we absolutely need more money in, but we need the money to be going to the right places, and it needs to be coordinated and integrated. So Cynthia gave great examples of what they're doing at Lakeridge. We at Holland Bloorview have collaborated with community-based organizations to open beds in their organizations where the money flows out of the hospital into the community to create an appropriate setting that allows us to discharge patients earlier, and other hospitals like Ronnie's and others to discharge patients earlier. But there are real gaps. Community home nursing continues to be a huge challenge to safe discharge, whether it's the elderly or children. And again, it goes back to money. Creating a workforce that wants to stay in those jobs, whether it's nursing in the home and community, nursing in the hospital. We need to create that capacity all along the continuum. What we historically have done is we've thrown money at a piece of the problem and haven't looked at the upstream and downstream impacts. And so the virtue out of the pandemic, if you can call anything a virtue, and I think Ronnie alluded to it earlier, is we're working more closely together than we ever have. So I think we're better able to co-create solutions across the entire continuum of care, from those children's mental health services out in the community or pediatric rehabilitation in the community, right-size the whole program for children. We have a plan in front of the government right now called Make Kids Count, which is about that right-sizing. So it's about moving the money where it needs to go.
All right, we have about 5 minutes left, and I have one question. I feel like with healthcare, if we're going to talk about it here in this province, there is obviously a conversation about privatization. More and more physicians, experts, and advocates are coming out to say that we're on the brink of broader healthcare privatization in Ontario. And I want to get, Ronnie, your take first. Does that worry you?
I think from a pediatric point of view, I know that privatization is not going to solve the problems we have been discussing today. And I think what we need to be careful about when we think about privatization is, given the scarce human health resources we currently have in the province, for example, we need to make sure that we not start to compete more among each other than we already are right now. And I think you have heard from all of us the same suggestions for solutions. It's not just money. Yes, we need some money. There are system changes that need to happen. Some of that have already been implicated or implemented actually over the last few months. And if you take it all together, I will go one step further, and I know I speak on behalf of my colleagues in our province. We will be, and we want to be accountable for all the changes that we are suggesting, whether it's related to system change, whether it's related to more money coming. We don't just want to have the resources. We will be accountable for this because we are determined to find a solution to the problem that I earlier said is, in my mind, untenable for a province like Ontario and, to be honest, like a country like Canada.
Cynthia, does that worry you at all?
I'm actually not afraid of those discussions. We have components of our system that is private already. When we think about eye care, dental, drug care, laboratory out services. And so what I would say is we have tremendous partnerships with those, individuals and those service providers. And if we can have discussions that are really around efficient use of our dollars and partnership, I think that those conversations we should actually be having. What we're going to focus on in our organization is the strong partnerships that we know need to exist. We're looking at leveraging everything that we can within our system, and then also leveraging in partnership with our community providers, whether they're private, not-for-profit, or they're part of our organization. And I think that's what the public expects of us. It really is about breaking down every silo and barrier that we can to deal with the fragmentation that we have and to create a better system of integration, leveraging our resources most efficiently and effectively.
Alan, I have one last question to you.
I'd like to address that.
Yeah.
I don't think it could have been said any better. So I'm not afraid of the discussion. I mean, if you look at physicians' offices across the province, they're all basically small private businesses. The taxpayer, my mother up in Peterborough, all she expects is she needs to get the health care she needs when she's going to get it. The surgical center that Cynthia made reference to, there's another amazing surgical center out in London that I spoke to some folks about at Christmas. We need to disrupt what we're currently doing because it's not working very well, it's not effective, and we need to take advantage of all the resources in our community to better serve Ontarians.
With that being said, is this the year we will see these changes? Because it looks, we're all on the same page here, it seems like, from all of our guests and what we're saying here. Will this be the year where we see these changes, or will we be back here next January talking about the same issues? How long can this all last?
Well, these are complex issues, they're systems issues, and we're starting to see a coalition of men and women leaders in this community start to think about systems. This is the single largest health management organization in North America, bigger than any one of the big groups in the United States, $80 billion plus. We need to think about this through a lens of systems and do a better job at planning. We'll be back here in January next year. I'll be back with the second year of our prescription for Ontario, a doctor's 5-point plan, and I'll report what progress we've made and where we need to focus on in the next year and the year after that.
We are going to have to leave it there. Alan, Cynthia, Ronnie, Julia, thank you so much for joining us up front. Thank you for all the work that you guys do.
Thank you.
Thank you.
Thank you for having us.
The Agenda with Steve Paikin is made possible through generous philanthropic contributions from viewers like you. Thank you for supporting TVO's journalism.